Okay, thank you. Okay, so basically, I'm going to provide a small a number of topics about what this virus is that's causing the current pandemic. And as you well know, we can see that I suggested it was basically spiky balls, okay, of virus that are causing this disease at the moment, and we'll be describing exactly what is inside, what is this virus about, and what is inside of it, and what are some potential places that we can attack it for now and in the future. So, um, can we have the next slide, please? Okay, so uh, we're going to be discussing what are these viruses, where did they come from, and how are we going to interfere with them causing harm now and in the future. Next slide, please. Okay, this is a typical cartoon of a virus that we're dealing with right now at the moment. And what it has is it has an RNA genome, a ribonucleic acid genome, that is described by this little in this cartoon is this long string here that has these uh, balls of protein that are closely associated with it that are called nucleocapsid proteins. And that protects the RNA within the virion structure that we'll be talking about shortly. This RNA genome has a considerable number of genes. It's the largest RNA genome of the RNA viruses, so the ribonucleic acid viruses, those viruses that use RNA as their genome to encode and also express the viral genes that are critical for making more of itself or reproducing itself with inside a cell. The um, the rest of the structure is that can be seen here. There's a membrane that surrounds this RNA genome that is derived from the cell. When the virus is leaving the cell that it's infected, it actually takes and picks up part of the membrane from the cell. And within that membrane, which is from the cell, there are a number of viral proteins that are jutting out of that membrane out into the environment. And the most uh, classic, or the one that makes this virus give its name, is called the spike glycoprotein, or S gene, in the virus, and we S for spike. And it's a large projection out of the membrane of about 15 nanometers or in size. Remember, a nanometer is a billionth of a meter, so we're talking about very small, but yet in the viral world, actually fairly large projection. And that's where it gets this virus family, coronavirus or coronaviridae, gets its name because of that crown shape, or coronos is Latin for crown, and that's where this crown shape comes from. These glycoproteins, virally coated, jutting out of the viral membrane that encases the viral genome. Also in this membrane are a number of other proteins that may have some importance, at least experimentally. There's an M protein and an E protein, and perhaps also protein that may be of interest is a hemagglutinin acetylesterase glycoprotein. We know in the famous influenza virus that there is a neuraminidase that juts out of the viral membrane, and that actually is the basis, the attack of that protein is the basis for Tamiflu and Relenza, okay, that can actually inhibit that protein from functioning, and that protein is very important for the virus to leave cells, infected cells. And so, in fact, we're not absolutely certain yet, but we may have a way of attacking this protein of this virus the same way as influenza. If we can find inhibitors of this acetylesterase, it may in fact reduce the effectiveness of this virus leaving the infected cells, just like in the influenza case. We're early, it's very early in experimentation for that. I'll describe a couple other places where we're have some potent enzymes actually being potent places that are actually being attacked at the moment. Okay, so let me see here. Okay, so let's go to the next slide. Next slide, please. Next slide. Can you hear me?
Sorry, I'm frozen here. Just a moment.
All right, that's fine. Okay, this slide is depicting a standard replication cycle of the virus. Before I describe some of the details and why do we need to know some of these details, before I describe this, where did this virus come from? This virus is a member of a rather large family of viruses. Again, the coronaviruses are a large family of viruses that infect many different animals, including birds, and specifically the ones we're mainly interested in are those that infect mammals. And this virus, when we analyze the genetics of it, we have determined that is in fact most likely bat derived from bats. And this was the famous SARS-1, or SARS, it's currently called SARS Classic virus. It was also came from bats, and probably through bats, a virus leaving bats to an intermediary mammal or animal of some sort that humans encountered in exotic animal markets in China. And we know that we're not certain of how we got this virus into humans, but the very first cases were in a seafood market in Wuhan area, and it's not clear if it came from bats. There were no bats at that market, but in any case, the virus probably passed from a bat. It was a bat coronavirus that was able to infect other mammals, which then encountered humans and was able to infect humans. Now, a quite interesting point regarding this virus is that it had a couple of mutations that were developed within the bat. Okay, as it was just infecting the bat, it had a couple of mutations that allowed it to bind with fairly high affinity this receptor over here. This little black figure here represents a cellular gene and protein called the ACE-E2 for angiotensin converting enzyme 2 protein. And that's there for completely different reasons, not to bind a virus, but the virus has taken advantage of this receptor. In the medical world, it's important for blood pressure. The virus just so happens by accident takes advantage of this receptor being in a wide variety of cells, and that spike protein, that S protein, heavily glycosylated protein that is found in the outer viral membrane interacts with this ACE-E2 protein. And it turns out that the mutations allow this which originally was a bat coronavirus, to infect our cells with greater affinity than would be suspected from a virus just jumping immediately out of animal to humans. So unfortunately, that was just by accident, but it happened, and that's how this virus sort of filters down into our lower respiratory tract. Dr. File is going to be talking about that, and affects us with relative efficiency compared to other zoonotic transfers of viruses from animals to humans. In any case, this interaction is critical. Okay, so the interaction is required between the virus and this receptor. It's brought into the cell by a process called endocytosis, which allows the virus membrane to fuse with the plasma membrane and enter into a organelle called the endosome. The endosome then actually becomes more acidic. During that process, it allows for the endosome membrane to merge with the viral membrane, uncoating. We call it uncoating, which basically what this means is it unleashes the RNA genome of the virus into the cell cytoplasm, which is an important event. Some of you may have heard about hydroxychloroquine or chloroquine. This has multiple effects on human physiology, but one of the cellular effects is that it sort of inhibits this endosome acidity and potentially the conformational changes necessary to allow for the fusion of the endosome envelope with the virus envelope. And so it may be interfering with this uncoding step. We don't really know for certain yet, although we have found that chloroquine can in fact inhibit virus infection in vitro. Okay, so that's one place where it may work. It has multiple other places that it works, and so it's very highly complicated. And whether it's has efficacy or not, we will need further studies with larger numbers of individuals. After this encoding of the viral genome, okay, which is now in the cytoplasm, it immediately can be bound by ribosomes in the cell, which actually then begin to translate the RNA genome into protein. And the very first early protein is a polyprotein that is actually involved in making more of the viral genome. And that is these proteins over here are basically the RNA polymerase. Okay, so the virus needs its own RNA polymerase in order to recognize its genome and then turn it into many, many copies of its incoming genome. So a single RNA molecule in the cell then becomes thousands of RNA molecules under the power of this RNA polymerase, which takes nucleotides and stitches ribonucleotides and stitches them together to make all the copies of the single genome that comes into the cell. Okay, so in fact, the reason why I'm talking about this is that this is a major experiment undergoing right now at the moment, clinical and also in laboratory, is that can we inhibit this enzyme?
No.
In fact, that's what
All right.
Devere, in fact, it's been found to inhibit. It's a ribonucleotide analog that the enzyme readily takes up and then causes a chain termination. Instead of completing replication of the viral genome, it terminates because it picks up this nucleotide analog, and then stops the replication, stops the enzyme from further functioning, and therefore stops the virus from making thousands of copies of itself within the infected cell. So that is a very promising agent, which is so far has been determined to be very, very promising. And so we may hear more about that hopefully in the near future. After the virus, the rest of the details are important for a virologist because they may be other spots where we can in fact inhibit it. In any case, at the end of the day, all of the viral proteins and the nucleic acids that have been made, the genomes that have been copied, assemble and then are released. Thousands of viruses are released out of the infected cell into the environment. And we know this virus has a very high infectivity. In a day, an individual infected with this can produce maybe 700 million viruses or so in a short period of time and found in their throat and nasal passages. So this virus is very productive. One other final point is that this virus uses the membrane that surrounds the viral genome. It is derived from membranes that are found in the Golgi apparatus. That's where glycoproteins are actually that's where proteins are glycosylated. And this membrane is actually fairly stable, or more stable than the cell's outer plasma membrane, where many other viruses bud off. And this membrane may in fact the stability of this membrane may in fact make this envelope virus a little more stable than we're typically used to seeing, such as the herpes viruses or HIV. Those are or certainly some of the arboviruses, those are very fragile viruses, mainly because the virus envelope is not very stable. Whereas, unfortunately, this virus picks up fatty acids or lipids from membranes that seem to be more resistant to bile and drying conditions than typically viruses that have envelopes associated with them have. Okay, next slide, please. So in summary, there are many more details, of course, and once I get started, I probably could carry on for far more time. But we need to let Dr. File, in fact, uh, uh, get to the very interesting medical aspects of this virus. And so here's a small summary of what I've been trying to say. There are members of a viral family that are RNA-based genome rather than DNA, which is what our genomes are based on. They have a prominent viral-coded protein. That's the S protein or spike, and that gives its picture, that prominent picture of the viral proteins extending out into the environment, that crown-like shape, really rather distinct shape under electron microscopy that we see in many pictures of the virus. It also has a fatty lipid shell that must stay intact for the virus to be infectious. In fact, of course, detergents or soaps of any sort are very effective at destroying this virus, because what it does is it rips off the lipid shell, and once that happens, the virus is no longer infectious, even if the RNA is intact. It does not matter. There are several points in the viral life cycle that we can attack to prevent its ability to infect or eliminate its presence once inside us. And at the moment, social distancing is the most powerful way to keep vulnerable populations safe until vaccines or antiviral therapy are developed. I must say that the latest data, one final point, the latest data has suggested that these viruses are although they can change and mutate, the viruses found in China, originally found in China, there have only been 4, 5 to 10 mutations of viruses found in the United States. And that small number is very positive in regard to developing a vaccine against the virus. In fact, although it's stable in the environment, it's genetically, which is a problem, its genetic stability, okay, meaning that the genes stay the same over time, is actually greatly to our benefit of developing a vaccine that will be very powerful in stopping this virus from causing havoc potentially in the next year if we can develop an effective vaccine.
Dr. DeLucia, I don't mean
Yeah.
to interrupt you, but we do have one clarifying question. Could you please repeat what the potentially very promising invention related to the transcription and translation is, please?
The remdesivir compound, I'm sorry, is that what there was?
I think I'm reading,
Yeah.
I think.
Yes, go, okay, so, yes, okay. So that drug is basically a nucleotide, what's called a nucleotide analog. It looks like the little bases, the components that make up our genetic material are called bases, okay, nucleotides. With the polymerase is an enzyme that stitches these together. And so you have to stitch all of them together in order to actually recapitulate our genes so that they can be passed off to our daughter's cells and our offspring. So viruses do the same thing. They have to stitch together individual bases in order to copy the incoming genome so that it can make many, many copies of its original genome that infected the cell. This analog is actually picked up by, it was basically first discovered with in Ebola virus studies. It was found to be actually effective against Ebola virus infections. So people immediately tried to use this with this virus, and they found some success. And what it does is the enzyme, which is a viral coded enzyme, okay, so it comes from the virus. And so that's a good thing, because we're not attacking something that's inside our cell. We're trying to attack something that the virus, it's specific for the virus, which helps the toxicity issues that could be arise because these viruses are so intimately involved with the cell. In any case, by attacking a viral specific enzyme or protein, this analog gets taken up by the enzyme, and actually then is stitched in with the other bases that the enzyme is stitching together in order to copy the viral genome. And once it takes up this drug, this remdesivir, it basically can no longer stitch any more bases after that uptake. And so that stops the viral enzyme from copying the rest of the viral genome. And if you can't copy the viral genome, the virus basically becomes is forced to be extinct within the infected cell. It can no longer make more of itself and can no longer infect other cells. Or a progeny virus can no longer be made. Does that help? I'll be around to answer any other questions that people have. So let's go. We should probably move on to Dr. File, and then I'll certainly be around to answer any other questions that people have.
Excellent. Thank you, Dr. DeLucia. Go ahead, Dr. File.
Well, thanks, Angela, and thanks, Nicole. It's a pleasure to be with everybody to discuss this very significant pandemic, which has had unprecedented public health impact, of which we're all aware. And so what I'd like to do is discuss some of the clinical aspects. And so if we can go to the next slide, please. Angela has already talked about this as far as the identification of this infection or the virus in China, specifically Wuhan. I want to make a point, however, that, and he already mentioned that this is a large family of viruses, the coronaviruses. In fact, there are about 4 that have been commonly infecting humans for decades that usually are associated with mild respiratory infections. In fact, they're a common cause of the common cold, so to speak. But now we know that we have these novel viruses. I mean, SARS is one, MERS is a second one, and of course, the SARS coronavirus number 2, which is associated with COVID-19, which can cause very serious infections. And Angela already said it evolves from bats, but it probably went to an intermediate mammal, and I'm showing you a picture of one that is a likely candidate. This is pangolin, and these are animals that are eaten actually as delicacies, and maybe our representatives from Wuhan can tell us about this, but and are sold in these markets in China. But at any rate, we know that the cases have been accumulated. It's obviously a pandemic now. It's virtually everywhere in the world. I'm showing you data from March 22, but this is already out of date. It says globally about 300,000. We now know that's over 500,000 globally. The mortality from the latest data suggests there's about 4.4% mortality. But this also means that most infections are mild. And in fact, it's estimated that about 80% of the patients who are infected with this do not need to go to any health clinic or health facility. It's usually a self-limited infection. So we know that the clinical manifestations are variable. In fact, it goes all the way from asymptomatic infections to very serious infections. We do know, however, that those who have underlying conditions, and particularly the older, are at higher risk for severe complications. And I'm showing you in that sub-bullet point about the mortality, at least in China. If you were from 70 to 79 years of age, the mortality was 8%. And if you were over the age of 80, it was all the way up to 15%. Now, in the United States, again, 5 days ago, the cases were 27,000, as you're probably aware. Now it's well over 80,000. The mortality is somewhat less. It's about 1.2 to 1.4%. But what obviously is we're aware now is the fact that this has sustained transmission within the community. And I'll talk about how that has implications for the communicability of this subsequently. We know it's transmitted primarily by air droplet, and I'll show you pictures of that. But basically, this is the moisture that you might feel if you're within 5 to 6 feet of somebody who coughs or sneezes. The virus can be contained with these in air droplets. So if you're within that distance, you're at high risk of acquiring this if indeed somebody has that infection. Now, we know from other coronaviruses, the normal endemic coronaviruses that causes the common cold, that this can stay on surfaces for a while, such as doorknobs, such as keypads, or those of computers. And so we need to be aware of that. And that's why it's important to disinfect these types of services very frequently. I already mentioned the possibility of asymptomatic transmission, which really is an issue when we consider how we can contain this. There is data that it's excreted in the stool. We don't know, quite honestly, if there's oral fecal type of or fecal oral type of transmission. Next slide. Now this slide on the first picture just shows somebody coughing. You can see the air droplets going into the air. And obviously if somebody's coughing and there's a lot of people due to close contact to that person, and there's a high density of people, you can see how a lot of people in communication with that, or at least in close contact, can acquire the infection. And you know that it first started in China, but then we know that other places where there's a density of population, such as even in cruise ships, or obviously now in New York City, that there's a high rate of transmission. We know that the rate of transmission of this particular virus, the SARS coronavirus, or SARS coronavirus number 2, actually has a higher rate of transmission than the normal endemic coronavirus. It actually has a higher rate of transmission than seasonal influenza. There's this concept called R0, which just really looks at the reproductive score, or a number of patients who are in close proximity to someone, how many of those people would be potentially infected. And that score is 2 to 4, which means that every patient who's infected is likely to infect somewhere between 2 and 4 other people. Now, if you compare that with seasonal influenza, it's usually only about 1. So you can see how there's increased rate of transmission. We've already mentioned that it can be likely, in a way, transmitted by touching surfaces that are infected, and that there is asymptomatic transmission. Next slide. And so this just looks at a pyramid, if you look in the middle of this slide, of looking at patients who have mild or asymptomatic infection, more serious infection, and then obviously fatal infection. I want to compare this with SARS, which occurred primarily in Southeast Asia and in China about 20 years ago, because in that particular infection, most patients who were infected, in fact, almost all patients who were infected actually became ill. And they didn't tend to transmit the infection until they became seriously ill. So this allowed for the termination of this epidemic, because if you quarantined everybody who was sick, then you essentially terminated transmission. On the other hand, if you have a large segment of the infected population who have only mild or asymptomatic infection, these patients may not be identified because it's so mild. Therefore, it's difficult to quarantine them, and that allows for increased transmission within the community setting. Next slide, and that's what we're concerned about at this present time. This is a pandemic, which simply means that there's evidence of ongoing transmission of the infection within multiple continents, and essentially every continent except Antarctica, I believe, now has cases, as you can see from this particular map, which is actually over a week old as it is. Next slide. Now, this is the first case that was reported in the United States. This is a patient who actually came from Wuhan. And as you can see on that shaded bar that has the numbers, this person traveled from China, from Wuhan. He, at first day back at work, he developed somewhat of a cough. The next day, some fatigue and some fever. Eventually, on the 4th day after coming back from Wuhan, he went to an urgent care center because of his symptoms. I'm going to show you a chest x-ray in just a second, which really was quite clear. And so he was sent home. But however, on that day, because of the concern that he had came from Wuhan, where there was the epicenter of the outbreak at the time, he was tested for this particular infection, and that eventually became positive. He was subsequently then admitted to a hospital the next day. You can see on day 6, the second day of hospitalization, he actually developed a fever. He had other symptoms, as you can see on that bar graph below, such as nausea, vomiting, diarrhea. This person was treated with one of those investigational drugs that Angelo mentioned, remdesivir, and he eventually improved and was able to be discharged. I actually am interested in this case particularly because the infectious disease physician who cared for this patient, actually contacted me on the day of admission on January 21 of this year, and informing me that he actually had admitted the first patient, at least, who was documented in the United States. Next slide. And I'm just showing you the X-rays of this patient on day 4. This is when he went to the urgent care center. I mean, it's a clear X-ray. He really had no evidence of infiltrate or pneumonia. And on day 9, you can see next to it, he does have sort of a patchy infiltrate in the middle of his left lung there next to the heart. But it wasn't really all that impressive of an X-ray. Next slide. Now, this is the results of 2 studies of patients who were infected with the virus and causing COVID-19, first from Wuhan, where the epicenter was, and then secondly from another province in China. And I just want to compare these because there is some differences here. Although both of them I put in bolded, if you look at both of them, they primarily all had, or at least a great percentage had fever, and a great percentage had cough. Now you can see the age up on the top row from Wuhan was slightly older than that from the other province. And I point that out because the people from the other province mainly were traveling to Wuhan. They tended to be younger, and they tended to be less comorbid conditions, because if you go down to the very bottom, you can see the mortality was different. I mean, in Wuhan, it was 4%. Indeed, if you had to go to the ICU, if you had a severe pneumonia due to this virus, it was 11%, whereas in the other province, it was 0%. I also want to point out a couple of features, because this is what we're seeing now, even in the United States, that patients who present with this infection tend to have a normal type of white count. It's not elevated like you would see in normal bacterial pneumonia. And then the other point is I've highlighted the results for procalcitonin. Now, procalcitonin is a biomarker that allows us to have some differentiation between viral and bacterial infection. And most of these patients had a very low procalcitonin, which suggested that this was viral and not bacteria. Next slide. And a very common feature that we look for is CAT scan findings. And it's typically, as shown here in this slide, bilateral ground glass type of infiltrates. And when we see this, we are quite concerned about the possibility of patients that we're seeing now having this particular infection. So these are the patients we're targeting to do the testing specifically. Next slide, please. So once the virus obviously became into our country, the first thing we wanted to do was try to contain it or to control it or reduce the spread into our country. And so we did that, as you're probably aware, by travel restriction. The administration actually put a restriction on people from China at the end of January. I think this did have some benefit because it reduced the speed with which the infection did come into our country. We then were quarantining patients who had come from China, and therefore who potentially could be infected with it. We quarantined them for 14 days. And as you can see at the bottom of the slide, now we've obviously changed the epidemiologic association with travel to the point that it's not just China, obviously, actually Italy, Iran, Japan, South Korea, now essentially all of Europe, we consider it a concern. But now I say parts of the United States, but now it's basically all of the United States has some degree of community spread. But obviously, primarily now the concern is New York. So early in the course of trying to contain this, when we would see patients like in January and February who would come from particularly China or Italy later, what we had as a slogan in our infection control department was we would want to identify, isolate, and inform. That simply means that everybody that came to our healthcare facility, we would ask them about travel, their travel history. And if they have traveled to any of these areas, we would isolate them. And then we would perform our infection control, and then we would consider doing testing to evaluate if they had this type of infection. When we isolate, we'd have to adhere to standard precautions, and you've heard about PPE, and I'm going to show you that in just a second. But that's the concept of control. The next slide, however, you know, we're transitioning to the fact that we know it's in the community. We're no longer able to stop it from coming in. It is in the United States. It is in our states. So what do we have to do to try to reduce spread from persons who are infected to non-infected persons? Well, first, we want to do good health practices. And you've all heard about hand hygiene. Since we know it can be on surfaces, we want to disinfect those surfaces, but we also want to wash our hands frequently, avoid touching our face, avoid sick people if at all possible, to disinfect surfaces, as I mentioned. And then we have the mitigation policies, which is social distancing, which simply means, since we know that the primary route of transmission is person to person, and it's usually within a 5-6 foot distance, if we can increase that distance of interpersonal contact, we know that we're going to be able to reduce the transmission. Since we know it's in the community, since we know that there's a certain percentage, we don't know how high, it may be a large percentage, but since we know that there's a certain percentage who are infected and are asymptomatic, we almost have to consider that anybody could be infected now. So that's why we have to reduce our contact to everybody so that we reduce the transmission. And of course, this is the concept that I'm sure you've all heard about, which is flattening the curve. Because what we want to do is reduce the speed with which new cases occur. Because as you've seen in New York, as we're seeing in some other areas, now even in the Detroit area, there's been a rapid increase of new cases that really overwhelms the healthcare system, and we want to avoid that. So if we can do this social distancing effectively, we can reduce the speed of new cases, we can blunt that curve, and that's what we're trying to do so that we're not going to overwhelm our healthcare systems. Next slide. And I want to point it out, it's very important. You've heard about personal protective equipment. Do we have enough? It's extremely important for all of our healthcare providers that now that we're all seeing patients, that we protect ourselves. I mean, our mission is to care for patients, but we have to do it safely. And we can do it safely if we use adequate personal protective equipment and we use it effectively. So you're aware of the need for gowns, the need for masks or respirators, the need for goggles or face shields, because we know that if you're in close proximity and those air droplets go into your eye, they can get into us as well. We need to use gloves. So it's really important that we have the availability of appropriate and effective personal protective equipment for all of our healthcare personnel. And doesn't matter what the role of that healthcare personnel is. Could be a nurse, could be a physician, could be a respiratory therapist, could be a dietitian. We just need to have safe, effective equipment so that we can care for our patients and still be safe. I'm just showing you on the right-hand part of this slide, myself actually being fit tested for one of these N95 respirators. So it could, because we have to make sure that we know how to fit these so that they're going to work very effectively and keep us safe. Next slide. And I think this is my final slide as far as how do we manage patients now that we are seeing them. Well, primarily it's supportive. Angelo already mentioned some of the potential agents that we might use to reduce the amount of virus. Remdesivir obviously is an antiviral agent that actually reduces the replication and therefore, as he said, the ability for the virus to replicate and infect other cells. This is investigational. It's undergoing investigational trials right now, clinical randomized trials. And so we'll know the true efficacy, hopefully within a couple months on the basis of these trials. He also mentioned hydroxychloroquine, how it affects the pH balance. We do know from limited studies, and I have to stress that they're very limited, that it may have some benefit. But again, we need clinical trials to show the true efficacy. You all have heard about the development of the vaccine, that it's in phase 1 trials now. we hope that this will be effective so that we'll be able to use this just like we do the flu vaccine to reduce the burden of disease and certainly mortality. So that sort of completes my clinical assessment of what we know now about COVID-19 and the SARS coronavirus 2 infection. We still have a lot of unanswered questions, such as what is the true incidence of asymptomatic bacteria, or I mean asymptomatic viral infection, and how long do we have to maintain this mitigation policy before we can feel comfortable about trying to get back to business as normal? Because obviously we're not as business as normal right now. So I'll conclude my remarks now, and I look forward to any comments or questions.